Hello, welcome to Pathagonia. This is Jay. Happy 2024. I hope this new year brings with you, for you and me and for us, a desire to learn more pathology, to consolidate our learnings by connecting different concepts, as well as learning new WHO and entities, as well as molecular translocations and alterations. Okay, without further ado, I am on my cytopathology rotation. Once a week, we give an interesting case conference, and I thought I'd present two cases that will be separated by two videos. One is focusing on soft tissue and another on GYN. So let's begin with the soft tissue. This is a 40-year-old female with a left thigh mass that measures on radiology 14 by 8 by 8 centimeters. A CT-guided needle core biopsy was done. On cytology, we see adipose tissue and mixed with striated muscle. On the periphery, you can see a little bit of anisonucleosis, meaning like the adipocytes vary in size. As you can see, there is some variation in size, and however, there doesn't seem to be prominent fibrous septae here. But let's take a closer look at the other areas of fibrous septae, especially here. I skipped the other images because I thought this image just showed the best representation of some atypical cells. As you can see in the bottom center right, there are two large cells that, compared to the surrounding cells, are at least 3 to 4 times bigger. And so that is definitely concerning for some worrisome features. And here is another representative area of this fibrous region, and we can see some nuclear or cellular anisonucleosis with some coarse chromatin and some enlarged NC ratio. So somewhat concerning. So what's your differential? My differential include lipoma with fat necrosis, although we should have seen foamy histiocytes, giant cells, and degenerated adipocytes. Intramuscular lipoma, because we did see the skeletal muscle, but it should not have the atypia that we have seen. Pleomorphic lipoma / spindle cell lipoma, again, that's kind of like they're related. If we aren't sure, you can do a retinoblastoma 1 IHC, and there should be a nuclear loss. And then usually this tumor is in the cape of the neck or the upper back, which isn't the case here. This could be an atypical lipomatous tumor or / a well-differentiated liposarcoma, and we'll talk more about what the difference is, as well as an unsampled dedifferentiated liposarcoma, where we sampled the atypical lipomatous tumor / well-diff liposarc, but haven't sampled that non-lipogenic sarcomatous transformation. So what is the difference between an ALT and a WDS? It's basically tumor's location. If the tumor is in the periphery, it's easy to resect, and once you resect it, there's no risk of metastasis. So it is considered atypical lipomatous tumor. However, if the tumor is in a deep-seated, difficult to completely resect location, like the retroperitoneum, the mediastinum, the spermatic cord, then we call it a well-differentiated liposarcoma. Of note and of interest, another soft tissue correlate is this ALT WDS, or I'm sorry, I don't know why I said WDS, I meant WDL, well-differentiated liposarcoma, excuse me about that. The analogous component is the chondrocytic cartilaginous component, where you can have a well-diff grade 1 chondrosarcoma if it's in a place hard to resect. And if it's easier to resect, then it's an atypical cartilaginous tumor. So cytology of well-differentiated liposarcoma and atypical lipomatous tumor, you'll see hyperchromatic atypical spindled cells near the septae and vessels. You'll have varying adipocyte sizes. You'll have fibrous septae between adipocytes and plus or minus lipoblasts, although you don't need lipoblasts to diagnose well-differentiated liposarcoma, atypical lipomatous tumor. And of note, if you do diagnose liposarcoma on a resection, not necessarily a biopsy, because you have the whole field of view, it's good to know that there are subtypes of liposarcomas. You have the lipoma-like, you have the sclerosing, and you have the inflammatory. What is a lipoblast? I talked about lipoblast. It's a precursor for adipocytes. Just as analogous to in heme land, erythrocytes, the precursors are erythroblasts, which, kind of tying it with micro, parvovirus B19 can attacks the erythroblast. Anyway, going back. Erythrocytes, the precursors are erythroblasts. Adipocytes, the precursors are lipoblasts. And cytologically, they will be multivacuolated with nuclear indentation or scalloping, as you can see here on the bottom left. You see that kind of multivacuolated, kind of pushing the nucleus of that lipoblast. So first of all, I have to give credit to Dr. Jared Gardner. He has an amazing video, a very comprehensive video of liposarcoma. And he helped inspire this kind of chart where you have, this is how I break down lipomatous tumors. We can call them benign lipomas. And your subtypes include, your angiolipoma, your spindle cell pleomorphic lipoma, and molecularly you'll have an HNGA1-2. However, you will not have an MDM2 CDK4 amplification. And then kind of more on your cancer categories, you'll have your well-differentiated liposarcoma, atypical lipomatous tumor that can become a D-diff liposarcoma. So I like to think of this as a spectrum, and just based on when you sample it and based on if it kind of de-differentiates, you want to think about whether this thing you sampled is a well-differentiated liposarcoma it's on its way to becoming a D-diff liposarcoma, or if it's just a well-differentiated liposarcoma, or if it's just really easy to know it's a D-diff liposarcoma. Again, just the bottom point is think of it as a transition. D-diff liposarcoma looks like you have your well-differentiated liposarcoma ALT region, but you also have this adjacent region that's a soft tissue sarcoma that's not adipocytic. And to test for this, you can do an MDM2 CDK4 gene amplification. Of note, your soft tissue correlate, this can be seen in a low-grade osteosarcoma. And demographic-wise, this usually arises in your 40s, 50s. Myxoid liposarcoma, you also want to think that it can become high-grade. You want to rule that out. This usually is in the deep dye 30 to 40-year-olds, so kind of like demographically at least our patient. You'll see these bland cells with delicate chicken wire vasculature set in a myxoid background. And you want to look for these round cell components, which is, if it's greater than 5% of your cells, you want to call it high grade. And it's important to call it high grade because that increases your risk for metastasis. Your round cell component kind of looks like sheets of kind of round blue cells. A little bit more vacuolated, I would say, compared to your other small round blue cell differential. And then molecularly, you'll have a FUS DDIT3 rearrangement T1216, or less commonly EWSR1 DDIT3, or translocation 1222. Lastly, your pleomorphic liposarcoma, you need pleomorphic lipoblasts histologically. Otherwise, you want to consider undifferentiated pleomorphic sarcoma. Whether it's pleomorphic liposarcoma or undifferentiated pleomorphic sarcoma, they are ugly looking. Like my face. No, I'm just joking. Sorry, it's late at night and I'm being silly. But anyway, demographically, it's a rapidly growing, it's a painless mass, usually in the extremities of 70-year-olds. And if you are unsure if it's a D-diff liposarcoma or a pleomorphic liposarcoma, you can do that MDM2. It will be amplified in D-diff liposarcoma / well-differentiated liposarcoma, atypical lipomatous tumor, and then it will be negative, and there will be a complex karyotype for pleomorphic liposarcoma. Well, thank you so much. I hope you enjoyed. Just to recap, you want to think about atypical lipomatous tumor and well-differentiated liposarc based on the location. Liposarcoma or atypical lipomatous tumor, there are subtypes lipoma-like, sclerosing, inflammatory. What is a lipoblast? It's a precursor for adipocytes. You'll have that scalloping and multivaculated. And then just, if you're thinking well-differentiated lipoma, atypical lipomatous tumor, always think in the back of your mind, could this be a D-diff liposarcoma? Because it's a spectrum. And to look for this, get that MDM2 CDK4. Myxoid liposarcoma, think, is there a high-grade component that's greater than 5%? And then if you're unsure, get your T1216 fish, FUS DDI-T3, and then pleomorphic liposarcoma will have a complex karyotype, ugly looking, and again, you need your pleomorphic lipoblasts. All right, thank you so much. Y'all have a great Tuesday. Tuesday. All right, bye.